How do I know if I will have vaginal delivery or cesarean?
This is the most common question asked by couples. I am going to tell you how I approach this question. As a doctor, during the course of pregnancy, there are certain conditions in which delivery is not possible or it can pose life-threatening complications for mother or baby or both. A doctor's job in this case is to plan cesarean at appropriate time and not allow the patient to go into labor. This is called a planned or elective cesarean. In cases where the baby is in transverse position, breech position, too large or too small, placenta is on the lower side, fluid around the baby is too much or too less, multiple times previously surgeries have been performed on the uterus are few examples of this. In other cases, I would examine the patient at the beginning of 9th month or at completion of 37 weeks. And from 37 weeks to 40 weeks, that is till the due date, we do periodic checkups to confirm that both mother and baby are doing fine. And we wait for the beginning of labor naturally. In case nothing happens till the due date, it's much more riskier for the baby to wait after crossing the due date, and the risk, however small it is out of proportion to the dire complications. So it's strongly recommended to deliver at 40 weeks, even though some do believe that the pregnancy can prolong for 15 days more even after crossing the due date. So on the due date, I examine the patients again to ascertain if the situation is favorable for delivery and whether we can stimulate pain by using some medicines. That's called as induction of labor. The assessment is about what are the chances of delivery once the labor process starts with medicines. The assessment is not to see if the pain will start or not. Getting labor pains is a matter of time and dose of the medicine used, so it will happen sooner or later, but that does not ensure vaginal delivery. If odds are in favor of delivery, we go ahead with induction. If that's not favorable, it's safer to plan a cesarean in cases of post-dated pregnancy. Now, the best situation is when a patient gets into the natural labor process between 37 weeks and 40 weeks. Here we monitor labor to check for contractions, dilatation of cervix and descent of baby's head from the birth canal. We monitor progress of labor on these three parameters, and the fourth important point is the baby's heart rate. Some variations in the baby's heart rate are expected, and they are normal as long as it is in a certain range. If the heart rate is out of range, too fast or too slow for a significantly long period, it means that the baby's oxygenation is getting compromised, and while we take corrective measures to ensure proper oxygenation, it's important to expedite delivery so that the baby does not have any consequences like asphyxia and meconium aspiration syndrome. In this situation, a doctor has to assess the means for quick delivery. It could be cesarean, it could be vacuum or forceps delivery. So this is where an emergency cesarean may be required, and that's something we can never predict whichever tests we do beforehand. Emergency cesarean also may be needed in other situations where labor is stuck and not progressing, or mother's BP is on the higher side, bleeding is more, etc., and the list is very long. Finally, to answer the question about when will I know if it's delivery or cesarean, it's when baby is in your arms.